work has focused on drug-resistant TB and TB-HIV co-infection for the past 10 years. Dr. Shah has a breadth of experience in multiple high-burden TB and HIV settings, including South Africa, Ethiopia, Kenya, and Vietnam. She is currently with the CDC's Division of TB Elimination, where she serves as the Associate Chief for Science. I will now turn you over to Dr. Shah. Thank you.
Thank you, Evgenia, and welcome to our participants in this inaugural webinar. It is my pleasure to introduce our first speaker today. Dr. Jennifer Furin is an infectious disease physician and anthropologist who has dedicated her career to providing healthcare for the sick and poor around the world. She has implemented programs for patients with HIV and TB in resource-poor settings around the world, including Haiti, Peru, Russia, Boston, South Africa, and Lesotho. Dr. Furin has worked with patients who have MDR-TB since 1995 and has treated hundreds of children with the disease. She currently leads the Capacity Building Task Force at the Sentinel Project on Pediatric Drug-Resistant TB and serves as a regular consultant and strong advocate for children and families affected by this disease.
Great. Good morning, good afternoon, and good evening, everyone. And thank you, Sarita and Evgenia, for the nice introduction. Welcome to all the participants to our first webinar done in conjunction with the DRTB Training Network and the SWIFT project. For those of you who don't know about the SWIFT project, we're actually a group of volunteer implementers who are interested in helping bring new technologies and tools to the people who need them most in the field. And one of the big exciting developments in MDR-TB recently has been the introduction of new drugs and repurposed drugs. We've decided to focus our webinar series this year on Bedaquiline, since it is the first newly approved drug for the treatment of drug-resistant TB, and there's been a lot of activity around getting it out to countries who need it most. So I really welcome the opportunity to have this discussion with my colleague, Dr. Pepe Caminero, and moderated by Dr. Sarita Shah. You know, there's a lot of talk and excitement going around about Bedaquiline these days, but I think at the same time there are still some questions that people in the implementing communities have, as well as people in the Ministry of Health and from certain donors. And you know, there's been a lot of interesting conversations happening online about this, but at the SWIFT project we thought it would actually be good to bring these discussions out into a more open forum so that people have the opportunity to present the data and the perspective that they have on the use of Bedaquiline, and really engage in an open dialogue where people can ask questions, etc. The way I like to think about this is it's a great opportunity for us. It's actually the first time most of us have been able to introduce and use new drugs for the treatment of TB, and we thought it would be a great opportunity for us to sort of all put our best foot forward and really start a process by which we continue to engage with one another around these new interventions and repurposed interventions for our patients with DRTB. So I'm going to speak probably for about 10 minutes and then turn it over to Dr. Caminero. But just to review, the objectives of this are to sort of review the data that supports the use of Bedaquiline in the treatment of patients with drug-resistant TB. And we're going to focus specifically on drug-resistant TB today. I know there's been some discussion about Bedaquiline and pan-susceptible disease, but the data really exists on patients with drug-resistant TB, so we're going to talk about that. We're going to explore some concerns that people may have about the use of Bedaquiline in the patients with drug-resistant TB, and then really to discuss what's the optimal use of Bedaquiline in the management of DRTB to ensure the best possible outcomes for patients and programs. And sorry if I'm talking fast, everyone. I tend to talk fast when I'm excited and don't have a lot of time. So just to contextualize this, because we're going to review a number of the studies that have been done on Bedaquiline and the evidence base for it, I think it's important to recognize where we are in terms of the evidence base for the other drugs that we use for the treatment of drug-resistant TB and the current standard of care that's recommended for countries around the world. So, you know, DRTB, we've come a long way, and it's really interesting and exciting. The current recommended regimens for the treatment of drug-resistant TB are all based on experience, expert opinion, and observational data. None of these drugs have ever been assessed in patients with DRTB as a single agent, except potentially in some early bactericidal activity trials. And really what we're talking about is an evidence-based solely on observation. So it's exciting with the new drugs that we actually have evidence that's based on randomized clinical trials, which tend to provide stronger evidence for the use of a certain drug. But I do want to point out that with all the drugs that are already in use today, and with bedaquiline and delaminid and some of the other repurposed agents, these drugs are usually used in combination. So we're not here advocating or saying, bedaquiline is better than one of the other drugs. All of this occurs in a context where we use multiple drugs to treat drug-resistant TB. So bedaquiline is a new drug. It's in a new class of drugs. Its mechanism of action is it blocks the ATP synthase in Mycobacterium tuberculosis. And there have been a number of studies that have been done on this. I think Dr. Caminero is going to go into this in more detail. But early bactericidal activity studies, which are usually the first time that these drugs, TB drugs, are given to humans with tuberculosis, do show that there is an early bactericidal effect of bedaquiline. It starts around day 4. I do, however, want to mention that the role of the EBA trial, although a classic in the study of new compounds and repurposed compounds for the treatment of tuberculosis, is somewhat questionable. There are drugs that have shown no early bactericidal activity that show a clear role in the treatment of tuberculosis, and these include drugs like pyrazinamide and more recently clofazimine. There are some drugs that do show an early bactericidal activity but haven't gone on to show much sterilizing effect. So we know that EBA trials are done, but I just want to mention that sometimes the data may not necessarily correlate with clinical outcomes in patients. For bedaquiline, we also have data from phase 2B randomized clinical trials, as well as a large observational cohort of patients who have received the drug through expanded access programs. And as I mentioned, we always use the drug in combination with other medications, but one thing about bedaquiline, it has been tested as an add-on to MDR-TB therapy versus placebo. So unlike all of our other drugs, with the exception of delaminid, that are currently approved for the treatment of drug-resistant TB, we do know that bedaquiline as itself adds to the regimen. I just want to briefly mention the data that we talk about when looking at bedaquiline. It came from a study called C208. This is the randomized phase 2 trial that was done in 15 different global sites, in which 120 patients were randomized to receive standard MDR-TB therapy plus placebo versus standard MDR-TB therapy plus bedaquiline. The dose of bedaquiline was 400 milligrams once a day for 2 weeks as a loading dose, followed by 200 milligrams 3 times a week for an additional 22 weeks of therapy. So just quickly looking at the data, patients who received bedaquiline compared with placebo had much higher rates of culture conversion, and they actually had much more rapid culture conversion as well. And the 24-week outcomes showed a significantly higher rate of culture conversion. You can see the bedaquiline arm had 78.8% compared with the placebo arm at 57.6%, which was statistically significant. This lasted out to 120 weeks as well. So the evidence of the efficacy of bedaquiline, as I mentioned, is from study C208, and there's just some more specifics in this slide. The median time to culture conversion in patients who got bedaquiline was 83 days compared with 125 days, and this has important implications not only for the individual patients who receive bedaquiline, but we know that the more rapidly a patient becomes smear and culture negative, the less likely they are to transmit in the community. So this is a very important measure. I mentioned the 6-month culture conversion rates as well as the 120-week follow-up rates, again, which both showed statistically significant improvements in patients who received bedaquiline compared with placebo. And then when final treatment outcomes were assessed, and we'll talk about this in a minute using WHO definitions, almost double the patients in the bedaquiline arm were cured compared with the placebo arm. So bedaquiline appears to be an effective drug. It also appears to be a relatively safe drug. And again, it's important, I think, to contextualize the risks and the safety of bedaquiline with the current armamentarium we have of MDR-TB drugs, which have quite a significant number of side effects. So the evidence from bedaquiline safety comes from both the randomized study C208 as well as an open-labeled study called C209, which was a one-arm study for patients with quinolone resistance, aminoglycoside resistance, and XDR-TB. When we looked at the rates of grade 3 and higher events, so these are more serious adverse events, they were similar between the two groups, that's the placebo versus the bedaquiline group, but there were some higher rates of certain adverse events, the first being hepatic toxicity was higher in the bedaquiline group, and the second, and I just want to briefly talk about this for a minute, is there was evidence to show that QTc prolongation was seen more frequently in patients receiving bedaquiline. Now, QTc toxicity is now measured routinely in trials of new drugs. This is largely due to regulation by the U.S. Food and Drug Administration that was issued in 2005, in which new drugs are required to have thorough QT studies. QTc prolongation is not, in fact, an adverse event in and of itself. It's rather a risk factor for developing torsade de pointe, which is a serious and often fatal arrhythmia. So although higher QTc values were seen in patients who got bedaquiline, as well as a higher increase in QTc from baseline, I want to point out that there were no cases of torsade de pointe or any clinical cardiac events associated with the QTc prolongation. The list of drugs that cause QTc prolongation is so long, in fact, there's often dedicated websites to QTc prolongation. Many of them cause it, but none of them have, many of them do not have clinical events associated with them. The final point on bedaquiline safety is that there were 12 deaths that occurred in the study. 10 of them occurred in the patients who received bedaquiline compared with placebo. And this is something that's given us some pause around bedaquiline introduction. The investigators determined that none of them were related to study drug, but as many of you know, bedaquiline has a long half-life, and it may have been difficult to determine this. I just also want to briefly mention it's not just the randomized clinical trials that give us evidence about bedaquiline, but there's a large observational data set from more than 565 patients who received the drug via expanded access and compassionate use. And in fact, our next webinar, Dr. Francesca Conradi, who's had great experience with bedaquiline in South Africa, will be presenting their evidence and data from South Africa. Usually the drugs were given to patients with XDR-TB or highly resistant forms of TB, where historically cure rates and culture conversion rates are lower than 20%. The drug's been used in a number of countries, but the main countries for the observational data come from South Africa, France, Armenia, Latvia, and Georgia. And culture conversion rates as high as 75% were reported in these cohorts. So I just wanted to briefly touch on a couple of issues that seem to come up a lot in discussions about bedaquiline and its role in the treatment of MDR-TB. A lot of people are very concerned about the low cure rate seen in the trial. I do want to point out that overall rates of culture conversion and cure were relatively low in this trial. It's not entirely clear why, but a lot of it may have to do with the more stringent definitions of cure that were used in this trial. They used the WHO updated definitions, whereas if you look at a lot of the historical controls or the meta-analysis database, those include data from 2006, 2007, 2008, where very different definitions of cure were used both between programs and within programs. So, I think that that's important to keep in mind. And also, again, the comparison. At every time point in the bedaquiline randomized trial, better outcomes were seen with bedaquiline compared to placebo, and usually on the order of magnitude of 1.5 to 2 times higher. It's definitely worth touching base about the increased mortality rate with bedaquiline and why did we see this. But I do think it's important to point out that in the placebo group, there was a much higher rate of failure and withdrawal that was seen. It's presumed that some of these patients went on to die later. However, their deaths occurred outside of the window of specified follow-up for the randomized control trial. And this is important. There was a death in the placebo group that occurred later after the specified follow-up time period, so this was not counted. And I think that while all of us are concerned about an increased mortality rate seen in patients who got bedaquiline, we're equally concerned about patients who fail and who withdraw from therapy. And we have to contextualize this with the mortality rates seen in MDR and XDR. Ernesto Jaramillo presented a very interesting slide at at a conference recently comparing 5-year survival rates from almost all types of malignancy compared with that of XDR-TB. And XDR-TB has one of the lowest 5-year survival rates compared with even some of the most severe forms of cancer. And so, we're not talking about a disease that patients do well in. But, many countries are certainly following this, and one of the recommendations from the WHO for the use of bedaquiline is that there's active pharmacovigilance. I want to mention that the dose of bedaquiline is well established. It can be used based on short-term studies with nevirapine. There's some question about its use with lopinavir, ritonavir, although in a single-dose study there didn't seem to be any drug-drug interactions. These are important because a majority of patients in some countries do have HIV. It's important to point out that efavirenz does lower the concentration of bedaquiline, so these drugs are not recommended to be given together, and that the drug was not tested in certain populations, including children, the elderly, and pregnant and breastfeeding women, although in certain settings the drug could be given to these populations. We're talking about bedaquiline, but I don't want anyone to think we're just focusing on bedaquiline. There are a number of new and other repurposed drugs that can play an important role in the treatment of MDR-TB and that can be used with bedaquiline. I think a lot of the data and the success that's been reported in some of the compassionate use and expanded access cohorts, the drug was also administered with linezolid, which I think many of us feel is an ideal companion drug. The problem with linezolid is we don't know the optimal dosing yet, and there's certainly a relatively high rate of adverse events. Clofazimine is another drug that likely shows promise to use in regimens containing bedaquiline. I do want to mention there's cross-resistance between bedaquiline and clofazimine, largely mediated through an efflux pump. And both drugs do cause QT prolongation, but this combination will be assessed in the phase 2 of the STREAM study. Pyrazinamide looks like it's going to be a good companion drug, and there may be some synergy with this. The quinolones are really crucial in the treatment and success of patients with MDR-TB, but there is some caution about using bedaquiline with moxifloxacin, particularly because it also prolongs the QTc interval. Ideally, everyone would like to be using bedaquiline with a nitroimidazole, either delaminid or PA824. There's concerns about overlapping toxicity with delaminid and bedaquiline, and the safety of this combination is going to be assessed in an AIDS clinical trials group study that'll start in the second quarter of this year, we hope, and the combination of bedaquiline and PA824 is going to be tested in the NICS trial. This is just a summary, sorry for the micro print on it, looking at each of the drugs that we're currently using in the treatment of MDR-TB, the type of efficacy and safety data, and the numbers of patients treated. So you can see bedaquiline has a much larger body of evidence supporting it than the other drugs, with both a phase 2b trial that was completely randomized and the observational studies. But it's true that around the world probably just slightly over 1,000 patients have been treated with this drug. If you compare that with capreomycin and cycloserine, these drugs have a much more extensive use, although that's largely a historical bias. It kind of reminds me of the day when we were using D4T to treat everybody with HIV, and newer agents came out like tenofovir. I think there was a temptation at that point to say we have a lot more experience with D4T than we did with tenofovir, but innovation happens because we change what we've been doing based on data. So I just wanted to mention that as well. The WHO recommended the use of bedaquiline for the treatment of MDR-TB in June of 2013, so this is almost 18 months ago. There are 5 criteria they recommend be in place for using bedaquiline, and these include careful patient selection, close clinical monitoring, use in a combination regimen using WHO principles, the patient gives signed informed consent, and that active pharmacovigilance be used. We're currently developing with the WHO right now a implementation plan for countries that want to introduce bedaquiline, and several countries have already developed these. I'm going to close very soon, but I do want to mention it's very tempting, to get into this game of should we have bedaquiline, or should it be linezolid, or should it be delaminid, or should it be clofazimine? But I do want to mention none of these drugs have ever been compared head-to-head, and I don't recommend that those studies be done. We do know that the use of DRTB requires multiple agents, and I think it's important that we avoid prioritizing one over the other, but rather that we recognize right now we have, a small bounty in the treatment of drug-resistant TB compared to where we've been in the past. There's been a lot of discussion about doing further clinical trials with bedaquiline and the need for this before we introduce it widely in program settings. I hope I've managed to convince you that we actually have more evidence supporting the use of bedaquiline in MDR-TB treatment than we do for any of the other drugs. But for people who are interested in clinical trials, there are many trials planned right now with bedaquiline being used in them. None of them have been launched yet. The one that's closest to being launched is phase 2 of the STREAM trial, in which bedaquiline will be added to the STREAM regimen to see if it can go from 9 months to 6 months, and bedaquiline will also be assessed replacing kanamycin. But even under the best possible circumstances, if studies are to start this year, it's unlikely that we'll have any results until 2020. So the question that comes up is, do we wait until 2020 to have these results, or do we have enough evidence to start using bedaquiline now? And I believe we have enough evidence to start using it now. So just to close, we have both phase 2b data and observational data that show that bedaquiline has a very clear role to play in the treatment of drug-resistant TB. It must be used in combination with other drugs. There are certainly logistical issues around getting bedaquiline out there, but I think it's important we not confuse these with a lack of science. And we know we need a global partnership to use the drug in an optimal fashion, which is what we're hoping SWIFT and other things can do. Finally, I just want to close with a recommendation from an article that was published in The Lancet last year. And this article is important because it was presenting points of views from the community. And in the beginning of the article, they state it's unclear yet whether bedaquiline has a role in the treatment of MDR or pan-susceptible TB. But after going through their arguments, what they conclude is that bedaquiline offers an important addition to existing second-line regimens. It merited accelerated approval. The problem has been that countries have been slow to approve bedaquiline, which leaves many patients without access to this life-saving drug. So I will stop there and we'll turn over to Dr. Caminero. We're going to be taking, so Dr. Shaw is collecting them right now. So thank you so much, everyone, and I introduce you now to Dr. Caminero. So thank you.
Thank you, Jen. As Jen said, we'll be taking all the questions at the end of the presentation. So I would now like to introduce our second speaker. Dr. Pepe Caminero has been working as a chest physician in Las Palmas, Spain since 1986. He joined the International Union Against TB and Lung Diseases in 1996, and since then has worked in various aspects of TB control throughout Latin America. As a chest physician, he's worked closely in the management of MDR-TB patients, and from 2002 until 2013 has been a member of the Green Light Committee. In this role, he has advised more than 50 countries around the world in management of MDR-TB.
Okay, thank you very much, Sarita, for your presentation, and thank you very much also, Jennifer, for inviting me to be in this discussion. And good morning, good afternoon, and good evening for everybody. I would like to speak a little about bedaquiline. As you know, bedaquiline is the first TB drug to be approved in 40 years. After rifampicin, we have not been other drug approved before bedaquiline until now. This is very interesting. Why? Because bedaquiline, as you know, is working in a very different target in Mycobacterium tuberculosis, because it's inhibiting the point of the TPA syntax of Mycobacterium tuberculosis. When you can see here in this very good publication, very recent publication, where they are working the different drugs, we can see bedaquiline is working in a very, very different way. Then thinking about this, bedaquiline should be a very good drug to work in combination with other drugs. But also, as you know, the desirable characteristic of the antituberculous drug should be 4. I would like to analyze for you these 4 characteristics regarding bedaquiline. The first should be a bactericidal drug. Bactericidal drug is, for instance, isoniazid, a little less rifampicin. This is the capacity to kill the actively metabolizing bacilli. When we have a very bactericidal drug, we can reduce very fast the possibility to die of the patient and the possibility of the transmission. This is the first one. What about bedaquiline? In bedaquiline, we have only data about early bactericidal activity. You know, it's the capacity to kill in the first 2, 5, 7 days. Remember this very a little old publication, 6 years ago publication, analyzing what was happening with bedaquiline. This was the publication showing that the best pharmacodynamic and pharmacokinetic parameters for bedaquiline was with 400 milligrams daily. And this is the dosage we have until now. For this reason, we are giving 400 milligrams in the first 2 weeks for all the patients. And this is probably the most important characteristic analyzing the early bactericidal activity. You can see here in the circle, this is the situation when we have 400 milligrams. And you can see here, if we can compare bedaquiline with isoniazid and also with rifampicin, in the first 2-3 days is much better for isoniazid and rifampicin. But after 4 or 5 days, of course, the EVA of the bedaquiline is more or less good. Okay, it's good, it's similar to isoniazid and rifampicin, but not in the first day. Okay. Also, it is very important to analyze this publication because we are speaking. What is the conclusion? Significant bactericidal activity of 400 milligrams of bedaquiline was observed for day 4 onward, and was similar in magnitude to those to isoniazid and rifampicin over the same period, but not in the first 4 days. Then bactericidal activity, EVA, okay, more or less good, but it's not as good as isoniazid or rifampicin. Also, it is very important to analyze these 2 years publication. Speaking about the EVA also, or the 14 days EVA, or different association. Remember, in this publication, the best capacity to kill in the first 14 days was for PA824, moxifloxacin, and pyrazinamide. This is the ideal. But when you analyze in this study what is the EVA, the 14 days EVA of bedaquiline, was a little poor. Much poor than these other 3 combinations. Then, of course, we can have a little EVA, but not very good. Okay. And also, you have this very recent publication, published some months ago online, and only this month in the Blue Journal, the American Journal of Respiratory and Critical Care Medicine. This is analyzing the bactericidal activity of pyrazinamide and clofazimine alone or in combination with pretomanid and bedaquiline. Of course, the best EVA in the 14 days EVA bactericidal activity was for this combination bedaquiline, pretonamide, and pyrazinamide. But when you have not pyrazinamide, is much more or less. This is like, we know probably bedaquiline with pyrazinamide are working very well in the 14 days EVA. Probably bedaquiline alone is not as good. Okay? This is also very important to analyze. Then, conclusion regarding the possible bactericidal activity of bedaquiline. Of course, significant bactericidal activity of 400 milligrams bedaquiline from day 4 onward, basis in the 2008 publication. Similar in magnitude to isoniazid and rifampicin over the same period, but it is not very good. It's not as good as isoniazid and rifampicin, and probably also not as good as levofloxacin, at least high doses levofloxacin. Okay, the second characteristic of the drugs, for the best anti-TB drugs, sterilization. This is the capacity to kill the dormant or semi-dormant bacilli. This is the same that to avoid the relapses. Of course, we have not any publication analyzing the relapses with bedaquiline, but we have some surrogate for sterilization. Probably one of the best surrogates for sterilization while we are waiting for the study analyzing the relapses is the culture negative at the end of the second month. This is the speed of fall in CFU in sputum during first months of treatment. And in this situation, the 2 most important studies published with the bedaquiline, remember this Diacon study, New England, 2009, Jennifer analyzed it before for you. This is okay. The addition of bedaquiline to the standard MDR-TB therapy reduces the time to conversion to a negative sputum culture as compared with placebo. Then, probably a little sterilizing activity, and increase the proportion of patients with conversion of sputum culture, 48% versus 9%. Then bedaquiline added to this combination to the standard WHO MDR-TB regimen, of course, can have a little more sterilizing activity. Also, the very recent publication, also by the same group, Diacon, analyzing the randomized assigned 160 patients with newly diagnosed MDR, bedaquiline reduced the median time to culture conversion as compared with placebo from 125 days to 83 days, and increased the rate of culture conversion at 24 weeks. This also an indirect, probably evidence that perhaps bedaquiline can have also sterilizing activity, at least when we are adding to the WHO regimen. Okay, you can see here the regimen. This is the same in the time to culture conversion. You can see here the placebo plus background regimen, and here with bedaquiline. After 4 weeks, especially after 4-8 weeks, you can see the time to culture conversion is less. This is an indirect, as I told you before, evidence that probably can have sterilizing activity. Then, speaking about this new capacity, sterilizing activity, in Spain there is not a study analyzing the relapses in regimen with bedaquiline. The higher rate of culture negative at the end of the second month is a surrogate of the possible sterilizing activity of bedaquiline. But don't forget, this is synergistic sterilizing activity with pyrazinamide. Probably it's because we are giving many times at the same time that pyrazinamide. Going to the third characteristic, the capacity of bedaquiline that we are adding to a different regimen of the prevention of resistance in combined drugs. And in this situation, we have not practically any evidence. Only in the same study we analyzed it before. Remember one of the conclusions. In addition, none of the patients who received bedaquiline added to the WHO standardized MDR-TB regimen acquired resistance to ofloxacin compared with 22% of those on placebo. We have only this evidence. In this situation, of course, adding bedaquiline to the same regimen can prevent a little the probability to acquire resistance to the fluoroquinolones. This is very little evidence, but of course we have this data. And the last one has been analyzed also by Jennifer, having the minimal toxicity. Remember the first study, the first RCT, randomized clinical trials, the difference was only with nausea, occurring a significantly higher proportion in patients with bedaquiline compared with the placebo group. Also, as Jennifer told you before, to increase in the mean corrected QT interval were observed in both treatment group, okay, with intergroup different ranking for 1 to 8 to 10 milliseconds, okay. But this is not relevant in this study when we analyze it. Of course, analyzing the second RCT published last year in New England also, you can see here bedaquiline, you can see here placebo, practically the same. Here there is not any evidence that adding bedaquiline can be a little more toxic or with less tolerance. Of course, also Jennifer analyzed it before for you, the QT prolongation. At the moment, we are very worried about this. But when we analyze this, the most important study, this is about in 2014, New England, and at study week 24, the mean change from baseline in the QT was an increase of 15 milliseconds in the bedaquiline group and an increase of 3 seconds in the placebo group. Only one patient had a QT prolongation for more than 500, and there is not report of clinically significant arrhythmia during this trial. Of course, bedaquiline can prolong the QT, of course, but this is, in my opinion, we can manage more or less well this possible adverse effect. And regarding mortality, I think we need more data about this, but of course, in all the study, we have more mortalities about in the different, in the regimens when we are adding also bedaquiline. You can see here the mortality 13% in the bedaquiline regimen regarding compared with the 2% with the no bedaquiline regimen. Also, always is the same. Of course, when we are analyzing this toxicity, especially mortality and especially the QT prolongation, probably bedaquiline is not a good drug. But don't forget, I like a lot this conclusion of this Mongotti publication in Lancet. Even in the absence of data from phase 3 trials, this is with bedaquiline, the existing safety and efficacy data for bedaquiline are supported by more than high qualified clinical investigation, 1 phase 1 trials and 3 phase 2 trials that they see for any other drugs used to treat drug-resistant TB. And don't forget that most of the existing second-line drugs were developed decades ago and had insufficient robust efficacy and safety data for RCT. Many of the second-line drugs used to treat drug-resistant TB might not receive approval currently. For instance, I can see we are using a lot of cycloserine. We are waiting one approval for cycloserine now, probably never will be also with PAS and also for many other drugs. I think this is very important. Then, the conclusion. What is How is bedaquiline regarding this desirable characteristic of the drug? Regarding bactericidal, of course, it seems significant bactericidal activity of 400 milligram bedaquiline from day 4 onward. Sterilization, I analyzed you before, the higher rate of culture negative at the end of the second month is a surrogate of the possible sterilizing activity of bedaquiline. Prevention of resistance, very limited data, but it seems could be, especially avoiding the amplification to fluoroquinolones. And in the minimal toxicity, of course, it's not minimal toxicity. It's a little controversial, but in my opinion, this toxicity is more or less easy to manage, is in my opinion. Okay. Then, this is regarding efficacy. We are finishing this presentation. Bedaquiline, regarding this characteristic, is a good drug. A little bactericidal, probably sterilizing, moderate and controllable toxicity. But this is my question also, Jennifer told you before. However, in Spain reduces the median time to culture conversion as compared with placebo, and increases the rate of culture conversion at 24 weeks, and at 120 weeks, the cure rate is poor. Just for MDR-TB patients, don't forget in the first RCT, only there were MDR-TB patients, only MDR, not XDR, not pre-XDR. And in the second publication, in the larger publication, 85% of the patients also, they were MDR, only 15-20% of the patients were pre-XDR and XDR. Then 58%, even with bedaquiline, for me, is very poor. Of course, better than in the placebo group. What is happening then here? This is my question, okay? And don't forget that in the very recent publication in France, the French publication in the Google Hermetic study, when with bedaquiline, the conversion was 97%, don't forget that practically of this patient, 94%, bedaquiline was given with linezolid. And in my opinion, linezolid is, of course, a very, very good drug. Probably a lot of this very good action could be also by linezolid. But this is my situation. Why, if the drug is more or less good, why this very low rate of cure, even in the arm with bedaquiline? Because don't forget, when we review what is happening with the MDR, remember the first meta-analysis. What was happening with only MDR-TB patient? Cure rate 62% without bedaquiline. And you can see here, without bedaquiline, curing more than in the bedaquiline regimen. The second publication was the same. You can achieve even 69% without bedaquiline, better than in the RCT with bedaquiline. You can see here also, this is the very good 2010 meta-analysis published regarding XDR. Even in the patient with XDR, if you are using a new fluoroquinolone, the rate of cure is near 60%. Without bedaquiline in XDR, not only in MDR. And in this very recent, a very good publication, 1 year ago publication, Dennis Falson and all the team, also it was the same. You can see here treatment success for MDR-TB only, also the same with MDR-TB only, without bedaquiline curing 64%. This is also my most important concern, okay? Then, what is the current role of bedaquiline? I think bedaquiline is a good drug, but I think we need much more studies analyzing what is the authentic role of bedaquiline, okay? The bedaquiline implication for improving treatment of drug-resistant TB and possible implication to create sorted first-line regimen for treatment drug-susceptible TB is still unclear. I think at the moment we have not other choice. We need to use bedaquiline, and I think it's a good drug. I think we need more information, much more information, to see what is the authentic role or the authentic support of bedaquiline in the different regimens. Thank you very much.
Thank you, Pepe. Thank you, Pepe and Jen, for your thorough and thought-provoking review of the evidence for bedacoline's role in MDR and XDR-TB. I think you shared with us your excitement about this time in MDR drug development and MDR-TB treatment. And just this past December, we heard the news from USAID and Janssen for their plans to provide 30,000 treatment courses to low and middle-income countries with bedaquiline. So now really is the time to consider the role of bedaquiline in treating patients with MDR and XDR-TB globally, and provide countries and patients and TB programs the support needed to scale up treatment effectively and safely. Both of you highlighted some of the outstanding issues and gaps in knowledge in how we use or monitor bedaquiline, including issues of acquired drug resistance and cross-resistance, drug-drug interactions, and we have a number of questions from our participants about drug-drug interactions, which we'll come to in a minute. We still have gaps in knowledge about how to use this drug in special populations, including children, pregnant women, persons infected with HIV and hepatitis C and liver disease, just to name a few. However, I think we've heard from you that the early data from sites that have experience implementing bedaquiline are very favorable, particularly South Africa, France, where we are seeing higher culture conversion rates than seen in the trials, and overall fewer QT effects, particularly from the South Africa experience, where they're treating pre-XDR and XDR adults. So while there are cautions to be aware of when using this drug, or many of the drugs that we use in treating MDR or XDR-TB, which are very toxic, the goal of our session today is to share the data and the implications for guiding the use of bedaquiline in patients who could benefit from it. So I'd like to now move to the questions we've been receiving, and many of them relate to use of bedaquiline with other drugs. So Jen, if you could take the first question. We have a question here about what is the optimal dose of clofazimine with bedaquiline, as we know that clofazimine is often used in treatment of MDR-TB and increasingly being looked at in treatment shortening trials.
Sorry about that, I didn't unmute. So, you know, there's still some unresolved questions about the dosing of clofazimine, but if you look at in the clinical trials as well as in the expanded access programs where clofazimine was used, the dose was 100 milligrams a day, and I would refer the audience to a recent publication in Clinical Infectious Diseases of a randomized clinical trial done in China with clofazimine by Tang et al. So we recommend 100 milligrams a day. I do just want to point out, just to point out, there is cross-resistance between bedaquiline and clofazimine, but the drugs seem to work in a different way. We're not sure of the precise nature of clofazimine in terms of its mechanism of action, but when we see the cross-resistance, it's mediated by an efflux pump. You know, there are some people, if you have resistance to clofazimine, you may want to use delaminate, although accessibility to delaminate is an issue. So in the studies and the compassionate use programs, it's 100 milligrams a day.
Yes, I agree. We should use 100 milligrams, but in Spike we are using at the moment in the stream 2, both drugs. I am not very clear both of them can be complementary. Even we analyzed this publication I showed you yesterday and before, regarding the last publication this morning in the Blue Journal, when you are adding both clofazimine and bedaquiline, they are not supporting a lot. I think we need to know what is happening with both drugs, because if they have the possibility to have cross resistance between them, probably they can have a very similar option. I don't know exactly, no? And I think
so just to point out, Pepe, the cross-resistance is actually mediated by an efflux pump, not by a similar mechanism of action. So, and the EBA trials are always very interesting, but the data that's coming out of programs using both shows that there's better success rates. But I agree there's a need for more data, but right now if you're looking at trying to construct a regimen, I think clofazimine and linezolid are good options.
yes.
Okay, another question we had was regarding differences in culture conversion or cure rates between patients treated with bedaquiline and either moxifloxacin or bedaquiline and levofloxacin. Do we have data on differences in outcomes based on the quinolone that is used with bedaquiline?
I haven't. Sorry, this is Jen. I haven't seen any data comparing the quinolones head-to-head. The data I've seen, and this again comes largely from the French cohort, is that if a quinolone is included, the patients tend to do better. But I haven't seen any data comparing which quinolone. Pepe, I don't know if you have.
No, there is not evidence. But probably we are combining, we have to think, if we have no problem with the QT prolongation, the ideal is to combine, of course, bedaquiline with moxifloxacin. When we have problem, usually we are combining in most of the patients with high doses levofloxacin. And of course, with this combination, it's working very well. But don't forget, when we have very good sensitivity to levofloxacin is working alone very well, and also with a little support for other drug can work.
Yes, and I think you raised the issue of the QT prolongation, which is a larger concern with moxifloxacin than with levofloxacin, and that I think is going to still be determined as we have more data from the coming studies. Another question we've had here is whether the drug-induced liver injury that we've seen in the Bedaquiline trials can be due to changes in the ARVs. I don't think we have that level of detail of information, but do we know if the change, for example, going from an efavirenz to an nevirapine-based regimen to avoid the drug-drug interaction, could that be the cause for the increase in liver enzymes that has been observed?
So unfortunately, Sarita, the registration trial of Bedaquiline did not include very many HIV-infected patients. So based on the trial, it's hard to answer that question. Just putting in a little plug, and maybe to get people to come back for the next webinar, the country that's had the most experience doing this is South Africa, and Dr. Francesca Conradi will actually be speaking about the data from South Africa at our next webinar on March 19th. So you know, I don't know that they've collected data to that kind of level. It's certainly an interesting thought, given that nevirapine is associated with higher rates of liver toxicity, particularly in patients who have a CD4 count greater than 250. So I'll turf it to Francesca's next presentation. Pepe, unless you have something else to add.
No, of course, this problem with the hepatic toxicity have been seen also in patients without HIV. Okay, but in very few patients, we don't know exactly at the moment, because remember, even with these RCTs, we had very few patients included. But remember, in the first, in most of the patients included in both patients had been HIV negative, and they can have also. But I don't know if it is very relevant. Okay, I would like also to address the question 3. The question 3 is for me. I am totally agree with the person asking us this situation, because when we are working in the field, especially with the MDR-TB patient, in the MDR-TB patient, we are assuming fluoroquinolone is not working, the second line drug in the table is not working. Then we are working many times with very few drugs. Sometimes PAS, very weak drugs, practically not working anything. Also, many times we are working with linezolid, as in this patient, bedaquiline, and many other drugs. What is happening? Many times we have problems with the toxicity with linezolid. For me, I cannot understand why we have to stop bedaquiline at the end of the 6th month. I cannot understand, because many times the regimen can be more or less good with linezolid, with bedaquiline, and with other many weak drugs supporting this combination. But if you are removing one of them at the end of the 6th month, especially in this patient, and we can see this patient many times, the patient is reducing the vascular load little by little, but the patient is not totally negative. Why to stop bedaquiline? I cannot understand. This is one of the most important questions. Why not? We cannot give. Of course, at the beginning with the interim approval, okay, but at that moment we need bedaquiline for 18 months, not only for 6 months. And this is, I think, it's one of the most important questions at that moment. And I think we have to press Janssen to achieve this situation.
So Pepe, this is Jen. I also agree with you, when you have a patient who's doing well. I think this is again where, it's great we're doing better clinical trials and have better data. It's a nice chance for the MDR-TB world to, get our act together and have these things. But I think this is a situation where we see some of the limitations. A drug is tested in a randomized control trial, and then the registration and indication is for exactly the way it was tested in the randomized control trial. So there was no magical reason to pick 24 weeks for bedaquiline, but it is what was picked. And so I think that the evidence is missing, but I do think this is where individual clinical providers, with assistance from some kind of clinical review or expert committee in their country or an international one, could make decisions on individual patient basis to continue the drug. I think what we have to say is there's no evidence from the randomized trial to support this, but I think you're certainly making a great point.
Yes, because especially some XDR-TB regimens with bedaquiline can be more or less weak. With bedaquiline, after 6 months, can be very, very weak, and the regimen can fail and can amplify the pattern of resistance. Then, of course, maybe we need RCT data, but while we are waiting, I think we have to use when the patient is not going very well and when we need this drug, especially in the XDR-TB patient.
Agree.
Okay, we have a couple questions here related to the cost and to the announcement from December by USAID and Janssen. So the question here is, what is the cost for a treatment course of bedaquiline? And I don't know if one of you want to take that question, Jen or Pepe. There's different prices.
Yeah.
So there's a range.
The price, no?
Yeah, so the drug is available through the Global Drug Facility, and the cost depends on which country you live in. So in lower income countries, the cost for a 6-month treatment course is $900 US. It averages out to about $4 a pill. You don't procure bedaquiline as a single pill, you procure the entire 24-week regimen. If you live in a middle income country, the cost is $3,000 US per treatment course. If you live in a wealthy country, bedaquiline runs on the order of $30,000. But for most countries, it'll be $900 or $3,000. The question about when the USAID and Janssen bedaquiline will be available is a good one. I think it was an exciting announcement to hear, but from what I understand, USAID and Janssen are still in the process of signing the agreement. So right now there are no details that can be made available. Just thinking in terms of a realistic timeline, I do believe that countries who have global fund projects and are treating patients will be eligible for it. But from the time that mechanism needs to be worked out until the drugs are available, I don't imagine we're going to know some of those details for another 3 to 6 months. So what we're encouraging countries to do is keep asking USAID, give them your input on how you would like to see this done. But if you've procured bedaquiline or are planning to procure bedaquiline with global fund money through the GDF, to continue that process, because it'll probably be several months before we even know how to begin accessing the donation, let alone have donated drug in country.
Yes, of course, it is depending. I think I fully agree with Jennifer. But for instance, in some countries in Europe, the price of one dosage, 1 day bedaquiline is 130 euros. This is near $150. This is only for 1 day. This is totally different. But of course, you can have, in many low-income countries, you can have all the 6-month treatment for around $900,000. And this is there is other question. This is difference.
Okay, thank you. So we have, go ahead, Pepe.
Yes. Maybe this is other question. Is there any difference in culture conversion of cure rate between patient treated bedaquiline with moxifloxacin and bedaquiline with levofloxacin? We have not any data. Remember, high dose levofloxacin could be can have a little higher early bactericidal activity at the beginning, in the first week approximately, than moxifloxacin. But don't forget that moxifloxacin has a better distribution in the lungs. And probably, for me, the ideal should be thinking in the work we are asking for bedaquiline, the possibility to use bedaquiline with moxifloxacin. But of course, we had the problem that we need data regarding these probably addition effects regarding the QT prolongation.
Okay, one question we have related to sort of the programs and the support for rollout of Bedaquiline, I just wanted to add here. WHO has put out guidelines for rollout of Bedaquiline, and they do have, five components that you described, Pepe. This is quite a bit of preparation for countries, and I'm wondering if both of you can talk about the role of WHO and the other technical agencies in assisting countries with rollout of Bedaquiline, especially these requirements for pharmacovigilance and informed consent.
Yeah, thank you, Sarita. It's a great point. So this is Jennifer, sorry. So the 5 recommendations put forth by the WHO are really to ensure that we use Bedaquiline in an optimal way. The goal is to really get access to the people who need it most. I mean, typically when we have a new drug or intervention for MDR-TB, the wealthy countries with low TB burdens get it first, and the poor countries that have high TB burdens get it last. So the goal is to introduce Bedaquiline and to do it in an optimal way. What I can tell you, having spent a number of months working on this with early implementing countries, is that most of the recommendations are relatively straightforward. Select patients who don't have a contraindication to the use of the drug, monitor them closely for side effects, and give them a regimen that's constructed according to the WHO principles. So really, any country that's doing good programmatic management of drug-resistant TB usually has in place these 3 elements. Having the patient sign an informed consent, most programs do have patients sign informed consent, although there will be a specific one for Bedaquiline. I think the reason is we just want patients to understand there's been limited experience in using the drug and that it could cause problems, contextualized, of course, in the setting of improved treatment outcomes. And there's a lot of work on the SWIFT project that we're working on, as well as with other actors, to help develop those materials. The pharmacovigilance component actually is being done for 2 reasons. One is, because of the side effects that are seen with Bedaquiline have been reported in the trial. But 2, in order to really establish a full profile of Bedaquiline, we need a cohort of about 10,000 patients. So this is something several global actors are working on. Right now, national TB programs need to know how to collect the data and have a system for reporting that data, but there's more to come. So what I would say is the WHO very much sees themselves as facilitators of this and are available and happy to help countries that want to introduce Bedaquiline.
Sarita, I would like to address the question 8, to speak a little.
Yes, okay, I have a question about a regimen for XDR-TB, and Pepe, we're just...
Yes, yeah, this is the question. Because there is an answer, and I would like to address, this answer is okay, I agree with this answer, but I would like to address this topic. Until 4 or 5 years ago, most of the XDR-TB patients, they were XDR because the patient used it before only the fluoroquinolone or only the second-line drug injectable, most of them. Okay, but now in many countries, especially in the low and middle income countries, most of the XDR-TB patients, they are XDR-TB patients because they have been a failure to the standardized MDR-TB regimen, WHO. In this situation, the current XDR-TB patients, most of them, or at least more than 50% of them, they have also resistance to ethionamide, protonamide, and cycloserine or Bactericidal. Why? Because this drug have been used in the previous regimen, failing this regimen. Okay? Then this is very important because in this recommendation, this is Bedaquiline, okay. Linezolid, okay. Capromycin. Most of the patients with XDR, they have XDR because resistant to kanamycin or amikacin. Don't forget that around 90% of the patients with resistant to kanamycin or amikacin, they can have also resistant to capromycin. In this situation, of course, you are giving capromycin, but probably capromycin is working only in 10-20% of the patient. You cannot account. Levofloxacin, the same. The patient have received previously in the category 4 regimen, in the standardized second-line regimen, levofloxacin or mesofloxacin. Probably the cross-resistant among these two drugs, we don't know exactly, but probably it's higher than 80-90% that we are giving levofloxacin or we are giving moxifloxacin, but we cannot account because probably will be not able to work. Okay? PAS, of course, could be a new drug in some regimen because they had not used it before, PAS. But remember, PAS is a very, very weak drug. Protonamide, probably used it before, okay? And probably a failure. Then, many times, even you are giving 1, 2, 3, 4, 5, 6, 7 drugs, probably you are giving only bedaquiline, linezolid, and clofazimine, okay? Then sometimes could be not enough. And many times you have to think, it is very good to add again protonamide. Remember, protonamide or etionamide can have a lot of adverse events, okay? And this is, okay, the regimen could be more or less good, but take in account this. If the patient has been a failure to the standardized second-line regimen, probably even with these 7 drugs, the regimen could be a little weak. And in this situation, please think that meropenem with clavulanic are working also very well in the clinical management. We have very few data, we know, but when we are using meropenem clavulanic or imipenem clavulanic with, for instance, clofazimine and linezolid, this combination is working very, very well. It's only I would like to address this topic.
Thank you, everyone. We're really out of time. It was a great discussion. Thank you to our presenters. Thank you for the great questions and everyone's participation. And as mentioned during the